We've got just a couple more people joining, it looks like. So I want to just go ahead and welcome everybody to the latest edition of Transplant Talks, a semi-regular series that we do here at Gift of Life. Today is Transplant 101, the basics. And we've got a great panel that I'll let Patty introduce you to in just a minute. But Patty, if you'll just hop onto the next screen.
Sure.
Want to make sure if you all want to make sure that you can see the speaker and not just all the participants, you can go ahead and you can go ahead and just click on view in the top right, and you can set that to show side-by-side speaker. And so that'll highlight whoever's speaking and just give you a good view of who the speakers are. Next screen. So just a little bit about Gift of Life. I am Julie Klima. I am the executive director here at Gift of Life. We are a nonprofit organization that promotes and supports awareness and success of organ, eye, and tissue donation through education, mentoring, and collaboration with partners and individuals in the transplant community. This program today is brought to you by Transplant Mentors, one of the two signature programs that we offer here at Gift of Life. And our Transplant Mentors provide insight, education, support, and encouragement to transplant patient candidates, new recipients, their care teams, and living donors. You can find out more about Gift of Life and about the Transplant Mentors program on our website at giftdonor.org. And with that, I want to hand you over to Patty Draper. Patty is the new program director for Transplant Mentors. She joined us in January after 7, I think it was, years at St. Luke's working as a transplant social worker. And we are thrilled to have her here leading the program. So Patty, over to you.
Great. Thank you, Julie. Julie did a great introduction. I am a social worker by trade, but I'm happy to be here new with Gift of Life as the director of the Mentors program. When I onboarded, it was already a very robust program, which many of you have participated in. I'm just trying to continue the legacy of mentoring people here in the Kansas City area and beyond. It's exciting to be here. And I'm going to go through and kind of introduce our speakers. Our first speaker is Shannon Maddox. She is a transplant financial specialist at St. Luke's Hospital of Kansas City. She's been there for the past 12 years. Prior to that, she worked 12 years in health insurance. She holds a bachelor's in education from Newman University. In her free time, Shannon enjoys serving as a resource and liaison. She also spends a lot of time with her daughter and other family members here in the Kansas City area. Cherie Morley is an APRN who specializes in hepatology and in liver transplant at the University of Kansas Health System. She graduated from KU with her bachelor's in nursing and then went on to earn a master's in science in nursing at KU as well. She holds a national certification from the American Association of Nurse Practitioners. She is a fellowship recipient from the American Association for the Study of Liver Disease. She has committed her career in liver disease and transplant. In her spare time, she enjoys traveling, cooking, and spending time with her 2 little boys. Matt Wilkinson joins us today. He completed his undergraduate work at the University of South Carolina. He then went on to do his MD and PhD at the University of Texas Southwestern Medical Center there in Dallas. His PhD mentor relocated to Mount Sinai in New York, and Dr. Wilson followed him there and went ahead and started his abdominal transplant fellowship at the University of Pennsylvania. He's been with St. Luke's since December of 2019. When he isn't working, he enjoys traveling with his husband, taking care of his saltwater fish tank, and playing with his 3 cats, Tiger, Luna, and Gigi. And then last but not least, we have Andrew and Vicki Widman. Andrew Widman is born in the Kansas City area and works as the principal and does wealth management. He's married to Vicki, who is a first grade teacher. They have 2 sons, Reese and Will. Andrew was born with a congenital heart defect, and he received his heart transplant at St. Luke's Hospital of Kansas City in March of 2017. He is also co-chair of our Go See Do event, one of our 2 signature fundraising events for the year. And as I mentioned earlier, Vicki is a first grade teacher in the Shawnee Mission School District and had the pleasure of being Andrew's main care partner during his recovery from transplant. So I just want to say a big thank you to all of our panelists. They together have amassed quite a wealth of knowledge related to transplant. This presentation, we're going to really try to go through the highlights of Transplant 101, just a sort of a really zoomed out view of what transplant looks like. So the first kind of the phase of transplant is what you would think of as the transplant evaluation phase. First things first is often finances. Shannon, can you speak a little bit to what goes into the financial clearance before someone is evaluated?
Okay, so when someone is in that referral phase, we basically will review their coverage, make sure they have adequate coverage for a transplant evaluation, and get authorizations as needed.
Wonderful. So when you say kind of get authorization, does that mean it's approved by their insurance to be covered before they even start all those tests and procedures?
Absolutely, yes. You make sure we have that in place. Sometimes a patient will have to be referred to another center. There's different contracting issues. So we make sure that they can come to the program and get authorizations before they even step foot in the door.
Okay, wonderful. Thank you. And then Andrew, I wonder if you or Vicki could speak to how this transplant evaluation phase was for you, kind of learning that you needed a transplant and entering into that evaluation phase.
Yeah, hi. So as I was referred for a transplant, that then started them looking at my health, and doing a full evaluation, and they ended up bringing me in. I was in there for 6 days, and they ended up doing pretty much every single test that you can imagine. Not only were they doing medical tests, but they were sending in the social workers and the psychiatrists, and they were looking at everything and making sure that I also had, people at home too, to support me when it was all done.
Yeah. So Andrew, you bring up a great point. The transplant team is a big one, isn't it?
Yeah. Oh yeah, for sure.
So this graphic I thought was really interesting. It kind of shows you all the people that are in the background going through transplant with you, that are kind of checking you out from every angle. Cherie, can you speak a little bit to your perspective on the multidisciplinary approach and why maybe that's important for a transplant?
Yeah, so transplant is, like you said, multidisciplinary. The patients undergo a thorough evaluation, not just from the specialist affected, the organ that they may need, because as we all know, one organ typically affects others. We want to make sure we're looking at the patient as a whole. So that's why we often require the help of our other colleagues, outside of, providers looking to see if you would be a good candidate. We also need to look at the whole picture of, the care needed after transplant. That includes, financial support, medication understanding, and, truthfully, just having that multidisciplinary approach helps a successful transplant go through.
Thank you. Andrew, you kind of spoke to this a little bit. Vicki, I'm wondering how was that experience for you? All those different people in and out and questions.
It was overwhelming for sure. To go through that the first time, without being, we didn't know that was going to happen. So
yeah,
it's to be able to explain it to other people. But there were people in and out of the hospital room all 6 days, and we felt confident because we knew they were checking him out to make sure that he was otherwise healthy for having the transplant eventually. So
yeah,
it was overwhelming, but we felt comfortable with it.
yeah. Andrew had a unique experience being evaluated for heart transplant. Many people get brought into the hospital for a chunk of time. Other people will experience this evaluation as an outpatient, scheduling tests as they're available, depending on what your transplant center recommends. And that's something that transplant mentors can help with, and also we can help you figure out how to communicate those questions and needs with your team. Andrew also commented that during his evaluation is a lot of tests. I remember when I would work, people would say, oh my goodness, they took so much of my blood. And really, they're just testing for so many different things. Dr. Wilkinson, do you want to speak a little bit to the information gathered and what y'all do with that information?
Sure. So as Patty put up here, you have a huge amount of testing that gets done. And part of what we're looking at is we want to make sure that we're doing the best possible thing for you. So as opposed to kind of looking at one specific problem when you go to the doctor, we're looking for anything that could be an issue or cause a problem after the transplant. So many of these tests are going to come back without a problem. If we're working someone up, and I primarily do liver and kidney transplants, and we're working someone up for a liver, we want to make sure that their heart's working well, their lungs are working well. And so someone like Andrew at a heart transplant, the heart team's going to want to make sure that his lungs are working well and his other organ systems are working well. And in some cases, it shows us we actually have to do 2 organ transplants. There are patients who get hearts and livers, patients who get hearts and kidneys. And so a lot of this testing is to make sure that you're in the best possible health you can be while still actually needing a transplant.
Thank you. Cherie, any comment on any of that stuff?
No, I mean, I think he sums it up perfectly. The goal of transplant is, to get you back to a functional status afterwards. We want you doing well. So that is why we have to look at every part of you to make sure that we get you to that kind of perfect position where we're aiming for and getting you back to your functional status.
Absolutely. Moving on to the next slide, after all of that information is gathered, that big interdisciplinary team we talked about, they sit down and chat about what all goes on. Cherie, do you want to talk a little bit about kind of the process or procedure for how a transplant selection committee meeting goes?
Yeah, so that same multidisciplinary team meets, depending on which facility you go to, typically once a week, and we gather all the information, all the testing that was done during your evaluation. We look at everything to make sure, hey, are you going to be an appropriate candidate? And that means not just are you going to be able to tolerate the surgery, but we want to make sure that after the surgery, the medications we put you on won't increase your risk of other complications. So during this testing in some patients, we find, hey, you know what, we should investigate, this finding a little bit more. We might find some concerns with a CT scan that said, hey, maybe you've got a little more lung disease that nobody knew about because we weren't testing or looking for it. So in some cases, we need to do some additional testing. But once that committee meets, they look at all the results and they decide, is this patient going to be a great candidate, or do we need some more testing? In a few cases, we find that there are problems and patients might need to be deferred until, XYZ can be further evaluated. And then in the, alternative situation, we find that maybe the patient is not going to be the best fit for a transplant because of findings during the evaluation. And that is why we are so thorough during this process, because again, we want to do what's best for the patient in the long-term effects.
Absolutely, thank you. Dr. Wilkinson, there was a question in the chat. How long does it typically take between starting the evaluation and getting through the selection meeting?
It really depends on the organ, and it gets very complicated in that sense, because depending on the organ you're transplanting, some organs you can't live without. So things like livers and hearts, the way the lists are done for those is primarily based on how sick you are. So someone like Andrew, who did an inpatient evaluation, we do the same for liver. If someone comes in frank liver failure, you may work that patient up over 2 or 3 days, have a meeting, and put them on the list. And liver, like heart, if you're the sickest person, you go to the top of the list. It doesn't matter how many people are on the list, you go right to the top of the list. For an organ like a kidney, where we have alternatives, there is dialysis, so you can do dialysis. In the meantime, most of the time that workup's going to be done as an outpatient, and kidneys are primarily allocated by wait time, so how long you've been waiting on the list, because we don't have enough kidneys for everyone that needs one. In terms of total time for workup, I would say an average for sort of outpatient, most places you're probably looking at somewhere between 30 and 90 days. A lot of what that depends on is going to depend on how much additional testing you need. You know, if you're a relatively straightforward candidate, that may be pretty small. If you have some other health issues that get worked up, or like Cherie said, if there are things that, oh, we did the CT scan and now we got to work up your lungs, getting you in to see the lung doctor may add a little bit of time to that.
Sure. Observing patient selection meetings in the past, I almost felt like the option of being deferred was the most common recommendation rather than going straight to denied. Do you think you'd agree with that, Cherie?
I do, definitely. You know, as patients are coming to us, and even in the pre-transplant phase, before they even get to the point of, hey, we need to move forward with that evaluation, we're already starting to look, are there red flags? Are there things we should be working up? Are there things that might be prohibitive to transplant? So typically we're trying to catch things that might be a red flag before we get to that even evaluation point. Again, there are the unfortunate times that, you know, it's not going to be the best option for a transplant, but when that happens, it's because it's what's the best answer for the patient.
Sure.
You know, obviously we want to transplant everybody, but we also, again, want to do what's best for the patient. So if it does come to there are valid reasons that a patient might need to be denied. But agree, typically not the answer.
Yeah. Another question from the chat is kind of wondering why more people with end-stage renal disease, maybe why aren't they encouraged more to find a living donor before they start dialysis? I think that's a interesting question. I'm gonna give that one to you, Dr. Wilkinson, since that's your wheelhouse.
It's a good question. I would say that you are probably looking at a group of people here who are more on top of transplant things. And so if you talk to most people here, they're going to say, yes, if you can get a living donor for your kidney, you absolutely should do that. We know that living donor grafts last longer. So if you get a kidney from a living donor, the average time is about 14 years. If you get a kidney from a deceased donor, the average time is about 7 years. The problem sometimes is, as Shannon was talking about at the beginning and Patty were talking about, it's a referral process to us. So I don't know every single person in the Kansas City area that has chronic kidney disease. There's no way I could know all of those people. So, you know, it comes to them either being aware of it, either their primary physician who first says, hey, you've got a problem with your kidneys, or when they refer them to a nephrologist, which is a kidney medicine doctor, the kidney specialist. When they refer it to them, that nephrologist sending the referral to us. And I would say, actually, a good number of people, nephrologists are aware of this, and there is actually a big push from the government to kind of get people onto transplant lists earlier, get them evaluated. So we are seeing more of that. One thing that sometimes limits it is either, number one, somebody doesn't have a donor, so that can be an issue or a limitation. And number two, all of this workup that we just talked about, the donor basically has to go through the same thing and be even more healthy. You know, if you have any question of high blood pressure or diabetes or any thought of kidney disease, we don't want to take out one of your kidneys and then possibly make you dialysis dependent in the future. So we do have a number of people that come in, and a lot of times their donors will go through the evaluation process, and the donor in their evaluation will find some reason that they can't be a donor. But we always advocate, if you can find a living donor, send them in, come in with a donor, you will get transplanted faster, and overall you'll likely have a longer lifespan for your kidney.
Thank you. That was a really wonderful answer. I think that, the next thing that happens after that transplant selection committee meeting is once you get the call that says, we're going to go ahead and place you on the list, then comes what can be a really difficult period. And for some patients, quite a long period. Dr. Wilkinson spoke to this about the comment on some organs are allocated based on degree of illness and other organs are allocated based on just simply time. Andrew and Vicki, do you want to speak a little bit about what this phase was like for you all?
Yeah, so I got released from the transplant workup thinking that I was going to go home that night and get the call, and that did not happen. And they actually sent me home with some meds, and I was on those meds. I was going in, working still, and each day just ticked away, and I just got sicker and sicker. And I ended up going back into the hospital and waiting the rest of my time there. But I think it was like 5 weeks or so from the day that I was released from my workup to the day that I actually got the call. Sometimes I have to lean on her to remember things because a lot of stuff happened in a short time.
That really does speak to the importance of the care partner support system, being that, the kind of the brains of the operation, sort of, Vicki, your role is a really hard one. How did you find yourself coping with everything during this waiting phase?
We were at home after we were listed. We were at home for about 2.5 weeks. And we had medicine pump that I had to change tubes for and become a nurse, which is, that's not what I studied to do, so it was very stressful. And then when he finally went in, because he was still not feeling well and was feeling sicker, and they said, yeah, pretty much you're not going home. You're going to stay here and wait for a heart. I was very relieved because then the pressure of physically taking care of him was no longer my job, and I felt like the more competent nurses and doctors could do it. So for me, that was a relief that he was put in the hospital.
Sure.
And then it was about 2.5 more weeks in the hospital before we got the call, and it was stressful. I felt comfortable there, and I never felt like this wasn't going to work out. I mean, I felt like somehow, someday, it's going to, we're going to get that call and continue our life. So it was stressful for sure.
That optimism was probably played a really important role, I would imagine. While people are on the transplant waiting list, it is really important for them to keep in close contact with the transplant center. Some patients, like Andrew, have the experience of that really short 5-week list. 5-week waiting time, as Dr. Wilkinson referenced, sometimes other organs like a kidney, you may wait for years. Shannon, do you want to make a comment about the importance of making sure all your financials are always up to date with your transplant center?
Yeah, and if I could, I failed to elaborate a little bit on the evaluation process with the financial consult piece. Yes. So when the financial coordinator meets with patients during the evaluation, and then annually it updates, like you're talking about now while they're on the wait list, Patty. One of the things that you do is go over really detailed transplant benefits and estimates of what we expect out-of-pocket costs to be for patients, and particularly of particular importance for their medications. So that's gone over with them, as well as like upcoming entitlements with Medicare. And at that time, we make suggestions if there are other coverage options available that might be better for them. Or, sometimes there aren't, but sometimes there are. So we'll make recommendations at that time if there's something that can help reduce expenses for patients, and then just kind of go over their budget and see if they are, prepared, or if there's any gaps in disposable income, or if they need to work on some fundraising or different things like that. And because insurance and life is fluid and changes so much, it is important that you really keep in touch with your financial coordinator or your coordinator and your team just about any changes in coverage, because we want to make sure that you're, ready to go when you get that call, when you're called in.
Absolutely. Thank you. And then kind of what everyone is referencing is getting the big call. Talking about the idea that the coordinator or someone from the transplant center could call you at any time of the day or night. We've all seen this excitement on TV. Something I used to always tell people was, you need to answer every call from every number, turn your call blocker off, because they'll often be calling from an anonymous number that you've never seen, or it'll look like a spam call, but no, this is when you really want to answer. Dr. Wilkinson, do you want to briefly explain the surgeon's process in this workup to before you call the patient to let them know that the organ's available? What does that look like for you as the surgeon?
Sure. So once you get put on the lists are maintained. It's done through a national system that is contracted out through the government. So everybody in the country that's looking for certain kinds of organs, there's one for kidney, one for liver, one for heart, one for pancreas, one for lungs. And when someone becomes a donor, they're put into that system. And then based on whatever specific way the rules of that system work, the system will then start to go through and say, this is the #1 candidate for this organ. That center gets a notification, and whoever takes that notification, so the coordinator, will call the surgeon on call. And they will say, we have this offer for patient X. What do you think about it? And the goal here is to try to transplant as many people as possible. So oftentimes we may get offers where we don't think the organ is a good fit for that person. Maybe there's a size issue depending on the type of organ. Maybe it's very big and you're trying to put it into a smaller person. Maybe you think that person had something in their medical history that makes that not a good organ for them. Maybe there's something in the laboratory studies. So many times you may be on the list and never hear about certain offers because the surgeon and the medical doctor on that side, whether it's a cardiologist for heart, a hepatologist for liver, a nephrologist for kidney, have decided that that is not a good organ to be transplanted. Because if we're going to go through this huge exercise, put you to sleep, put a breathing tube down, do this big surgery on you, put all these resources into you, we want to be sure that it's going to work and have the best possible chance of success. So I would say, honestly, for me, when I do a transplant, so a kidney is probably about 3 to 4 hours, a liver maybe is 6 hours. That's probably the least amount of time I spend working on it. We start getting calls 36, 48 hours in advance with organ offers, setting stuff up, getting you into the hospital. And so Patty makes a good point that once you're on the list, you want to have that phone ready and be answering day or night, because these calls will come at 1, 2, 3 o'clock in the morning saying, you need to come to the hospital now, the organ's here.
Yeah. And then, something I think is important to touch on is just the idea, Dr. Wilkinson, of the idea of like a false alarm call. Could you kind of speak to that a little bit? Because I think that is sometimes discouraging. I used to try to encourage people to think of it as almost optimistically. You're close to the top and your surgeon's being picky for you.
Yeah, so it can certainly happen that you would get a call and they would say, we have an organ we think will be good for you. But here's the thing, if I say I have a patient here at St. Luke's and they need a liver transplant, it's highly unlikely the liver is going to come from my hospital. The liver is going to come from somewhere else. And so all I get about the donor is computer information. I've never seen this person. I don't know all their medical history. All I get is what the donor people uploaded in the computer. And so oftentimes, not often, but we may go out to the donor site and say, hey, this doesn't match with what's in the computer and we don't want to put this organ in our patient. Or, in the case of a kidney, they may take the kidneys out and do a biopsy, take a little tiny piece of the kidney to make sure it's healthy and we think it's going to wake up okay. And we get that biopsy, we say, you know what, we don't think this kidney is going to make it. And so the coordinator may call back and say, hey, this is not the right one for you. When I meet with patients preoperatively, like an evaluation, I explain the same thing to them, and I say, honestly, you should look at it as a good thing, because it means that we're thinking about you and trying to get you the best possible organ. Yes, it's, you know, frustrating. We have patients who get called in 4 or 5 times before we actually take the organ that they're going to get. But again, the goal is to give them the best possible outcome and the best possible thing. And if we're going to go through this huge operation, put all this resource into it, and really change your life, we want to give you the best chance for success as well.
Thank you. Andrew, you had mentioned that you were in the hospital when you got the call. What was that experience like for you?
Yeah. So of course, the whole time that I was at home, I thought I was going to get that call there, because when you get it at St. Luke's, the phone number when they call you is the same number, no matter where they call you from. So every time I got that number, I thought it was the time, and it wasn't. But so yeah, I did get the call, although it was in person, and it was from my night nurse, Chris, who happened to be my night nurse when I was there for the workup, and then was there almost the entire time that I was there. And so it was just really neat for him to be able to come on shift at 7 o'clock, and it worked. So
that's really special.
Yeah.
Now I heard today that maybe you have a video of you getting this notification. Is that true?
So yeah, so I've got a video of me calling Vicki. Vicki was with me at the hospital the entire day, and she left to go home and be with our boys at around 7 o'clock or so. And a lady who I worked with and her husband were there with me at the time, and they got to see it. And so I had them video record from their phone, me calling Vicki and me calling my mom and dad too.
Oh, that's so nice. What a nice memory to have.
Yeah. Yeah.
Wonderful.
Yeah, it's neat.
So this is sort of what I visualize the transplant process is like, right, Dr. Wilkinson? Just like the game operation.
Exactly. It's just like that.
Great. And then after the surgery itself, you know, Dr. Wilkinson, is there anything you want to say that you think is important about the surgery itself that you like for your patients to know or to remember before we get into the post-transplant recovery?
I mean, I think the thing that I go through with all my patients is, you know, they have to understand this is life-changing surgery. You know, I always joke, this is not taking out your appendix, your gallbladder. This is life-changing surgery. And, you know, being sick before is one thing. Afterwards, the goal is to get you better back to functional status, but you're buying a whole lot of stuff with that. You're buying medications, because one of the things we haven't mentioned is that organ has come from another person, and our bodies are very smart. They're going to look at that and say, that doesn't belong here, and it will choose to attack it. The medical word for that is rejection, and it looks different in different organs. But when you get an organ transplant, you have to stay on medication basically for the rest of your life that calms your immune system down, and that goes into a lot of what Shannon was mentioning, making sure you can afford your medications post-transplant, because that's a lifelong thing. And so it's important to understand transplant is not just, oh, I had a surgery, like I had my appendix out, I saw my surgeon one time, and then I never had to see the surgeon again. When you get transplanted, you end up becoming part of, you know, that program and following with them basically for your lifetime to be managed that way. And as you get further out, most patients can be seen, you know, every few months and managed remotely, but it is a big commitment, and I think it's important that the patients understand that.
Absolutely. In that immediate post-operative phase, you know, obviously there are general surgical risk, pain, and things like this. Is there anything, you did mention rejection, is there any other surgical concerns that are common in that immediate post-operative period that you wanted to comment on?
I think one of the biggest things we probably worry about for all transplants, and again, I'm primarily an abdominal transplant surgeon, but I know that thoracic surgeons feel the same way, is bleeding is one of our biggest concerns. Because again, you know, Patty had that nice picture, that operation picture. We can't just take out the organ and put one in and hope it goes. We have to sew all the blood vessels back together. We have to basically put the organs back in so that they'll function the same way that they were before. And so certainly, one of the close things we watch is the labs. We look for how the organ is working, and that's going to depend on the organ. So in a kidney, is it making urine? Are your blood tests getting better? In the case of a liver, is it making things that help you do digestion? In the case of a heart, are they seeing it squeeze well? All the different things depending on which organ you're transplanting, it's going to be unique to that, but that sort of affects your stay. The shortest stay is probably going to be, a kidney, probably you could get out of the hospital in 3 or 4 days and probably go home. A lot of our liver patients, it's closer to a week or 2, and oftentimes they may go to rehab. Certainly for some more involved transplants, if you start talking about thoracic organs, they're definitely usually going to go to rehab. Most of our liver patients go to rehab. So it's not just the hospitalization. There's, more that comes with it afterwards as well.
Yeah. And kind of that idea of needing rehabilitation really speaks to how very ill some people are prior to transplant. Cherie, will you comment a little bit about some of that patient and family discharge education that goes on during that hospitalization immediately following the transplant?
Yeah, so immediately after transplant, you have to remember you were really sick. So it's a complete uphill battle. Yes, you have a functioning organ, but that debility, the weakness, the everything that you had prior to transplant, that doesn't go away right away, right? So it's a little bit of an uphill battle. It's close follow-up with your surgical team, with your transplant center, and it's like what Dr. Wilkinson said, a lot of close monitoring. Make sure that that graft, that transplanted organ is doing well, is doing what it needs to do, and then a lot of tweaking if we need to with medications, with getting you back to that functional status. I know we keep saying functional status because that is the goal of transplant, right? We want to get you back to where you were before you were sick. So rehab often is very much needed, and it's, sometimes an inpatient center, sometimes outpatient, but it's just working to get you back to your quote normal health.
Wonderful, thank you. Whenever I would be talking to people about transplant, we would always kind of really harp on the ideas of infection and rejection, kind of what Dr. Wilkinson had commented on, and then really just the idea of adherence. Cherie, do you want to chat a little bit about the education that goes on surrounding medication adherence and kind of the emphasis on that?
Yeah, so adherence, truthfully, adherence starts pre-transplant, right? We want to make sure you're adhering to the recommendations of the team to make sure that you're as optimized as possible pre-transplant, so that post-transplant things are going to hopefully go as smoothly as possible. That adherence includes medications. Immediately after transplant, you're going to see quick adjustments on your meds because we're still adjusting to know how much medication do you need to prevent that organ from rejection, to make sure that it doesn't cause any problems with other organs, because these immunosuppressions we give you, like Patty was saying, it does come with their own risks of infection. Most of them come with a risk of kidney disease and kidney damage if we were getting too much of it. So, getting that medication right, making sure you're getting the labs correctly so that as your transplant team, we can adjust your medications appropriately. We all have to work together to make sure things can get done correctly.
Yeah. You guys have kind of touched on this, the idea of transplant being that immediate after transplant phase being a bit of an uphill battle, not just functionally in terms of getting your sea legs again, being able to live independently, but also the idea of emotionally it can be quite taxing and overwhelming. And I'm wondering, Andrew, if you have any experience with sort of moving through some stages of acceptance to get to the point where you are now.
Yeah, I was lucky. I didn't really go through the guilty phase, although I knew that another family had a loss, right? And I had to deal with that.
Sure.
But I knew that it was not in my control. And so we had peace with that, knowing that, we weren't in control of what happened to the other person. And you know, I see it says blessed. We were very blessed with the gift of life,
Right.
right? With the gift that I received, because I was really, really sick, especially at the end there, and it was going to be days. So you know, it just came at the right time. But I mean, we were excited and we were sad and we were blessed and we were fortunate and you know, we did, of course, you know, we really celebrated our win, but understood on the other side that there was a big loss too.
Absolutely. And I think, you know, just as we as people move through life, all emotionally reacting differently to things, you know, we all react differently emotionally to stress. Vicki, how was it bringing him back home and having to kind of fulfill that role of care partner again?
At first, it was very nerve-wracking. I remember when the post-transplant coordinator came in to talk to us, you know, oh, it's so exciting. We get to go home. It had been 11 days since transplant, and that was exciting. But then it kind of dawned on us that, oh my gosh, we don't have doctors and nurses watching after you. You aren't hooked up to any machines that are going to beep and let us know something's going on. So it was kind of scary at first, the idea of it, but we felt comfortable with the medicines and knew when to take them. And it was great to get home because he had been out, he had been in the hospital for a month, and I kind of felt like getting home was going to be that start again of this new life that we were gifted.
Yeah. And in your day-to-day life, Andrew, do you feel like this takes an emotional toll, or do you feel like this is something that you just kind of carry with you?
I carry it with me, but I am reminded a lot. And I do sometimes I just stop and I'm like, I can't believe that I'm post-transplant. I was born with a congenital heart defect. And so I kind of knew in the back of my mind that this was always going to have to be something.
Sure.
But after in 2008, I was officially told that I was going to have one at some point in time. And luckily I had a lot of time to think about it. And so it is something that I knew was coming. I knew I was going to need it. And so, you know, I live with it, but it doesn't mean that I mean, I think about it all the time and how lucky I am. And just sometimes I just have to pinch myself that I can't believe that somebody was, you know, kind enough to donate their organs and that I got one of them.
Sure. After that hospitalization, you know, going home, as several of the panelists have commented, there is a pretty rigorous follow-up schedule. It's important to remember that just because you've had a transplant, you're not free of medical care. If anything, for some people, it's quite a bit more medical care. You're really going to be engaged in the medical system for the duration. So Cherie, I wonder if you want to comment at all on the medical recovery and some of the outpatient phase of care as you see it in the clinic.
Yeah, so you know, like kind of the outline shows on the screen, immediately after transplant, it's a lot of visits. It's overwhelming at times, but it's much needed. You know, we want to make sure everything's well. We want to make sure that you are prepared to go home and to be, you know, back to your normal self. So it is a lot of close follow-up. It might seem a little bit daunting, but again, we just want to make sure that immediately after transplant, everything's working as well as we can get it. As that stability shows in your, you know, course, then we can start extending the frequency. And again, eventually the goal is just hopefully seeing you, you know, once a year at some point, just having a nice follow-up saying, hey, how are things going? Things are great. Transplant's working well, you know, looking out for the potential complications post-transplant. We always discuss that. But I always tell our patients, you know, in the interim and the beginning phases of transplant, you're still so sick and still playing that catch up from how sick you were before the transplant. So it's time. We got to let time take its course to get you back to your functional status.
Do you think you could comment a little bit on how the labs help inform you in the immunosuppressant medications, making sure you're keeping people in kind of that sweet spot?
Yeah. So kind of like what we talked about with compliance with medications, those lab values are going to tell us if you're appropriately immunosuppressed, meaning your dosing is right where we want it to be. So it's not harming you, so not causing you to be more susceptible to infections, not too high that it could harm your other organs, like I said, with your kidneys on some of these medications. And B, that you're in that, good place where it's not too low, where that risk of rejection could definitely come up if your body is doing what it's supposed to do and, try to quote, fight these invaders. So it's a nice little range that we have to find. And once we find that sweet spot, typically we are able to keep you there, but, immediately before or immediately after transplant, it's kind of a chasing a number kind of game. We want to find your sweet spot. And some patients, it takes a little bit to find it.
Yeah. I wonder, Andrew, now that you're several years out from transplant, do you feel like being someone who is immunosuppressed or even just post-transplant in general, do you feel like that puts any limitations on your life, or do you feel like there's limitations set for you because of your post-transplant status?
A little bit. I mean, I'm before a couple of years ago, when I would be on a flight or something like that, I would wear a mask before anybody wore masks on flights, right? And I would board before everybody else, and I would wipe everything down. And now I guess that's a normal thing. But those are just things that I did even before this,
Sure.
And so, yes, and and we wipe down stuff if like we go out and eat, and I just make sure that things are clean. And so I was a little bit that way beforehand too, but now we're really, we haven't traveled anywhere in 2 years. I mean, we don't really do much, and it's because of that.
Yeah. I think you kind of got your transplant in a funny time too, right before a pandemic. And so then you had a few years of that kind of in between phase, and now you really have to buckle down.
Yeah.
And now we feel like the rest of the world is now living the way that we've been living the last 5 years.
Yeah.
I mean, now everybody's doing it because of COVID. So just being really careful.
Yeah.
And when we had when the boys would have a friend over, their parent always knew that the child couldn't have a cold and couldn't, they
Yeah.
just had to be real careful. We had a big thing of hand sanitizer right by our front door. So it doesn't make things hard. It just was kind of a different way of life to get used to.
Absolutely. And then, Shannon, as much as we hate to admit it, the financial piece of transplant really can't be ignored. It's such a big piece. Are there any long-term financial implications that people have to think about? Medications, insurance, things like this that you really want you would want people to kind of make sure they carry with them?
Yeah, I work primarily with kidney patients. So, they all usually have a Medicare entitlement. And we do have quite a lot of patients that historically maybe haven't had health insurance, and now they have this entitlement. But it does end after 3 years, depending on their age, if it's just because of their renal failure. So I really talk with them about the importance of insurance long-term going forward to support this transplant. So it's kind of changing your mindset that if you're going to lose Medicare, reach out to your team. We need to talk through what options you have, signing up for insurance through your job or through your spouse's employer whenever you can. And just that is so vital to really the long-term success of your transplant, is having access to those medications, and just, again, signing up for Medicare when you can, and just kind of really keeping on top of that, or reaching out to the team if you aren't sure, if you've had a change, if something has changed, and we certainly can let you know what type of options you have, even years out from transplant.
Wonderful. And then Dr. Wilkinson, we did have someone enter in a question when they registered. They were wondering if you could comment on the incidence of developing hernias or any long-term nerve damage. They had commented and said maybe they were having some nerve damage down in kind of nerve pain in their leg after their abdominal incision.
I would probably depend a lot on the incision and what kind of transplant. I mean, the
Sure.
only two that would probably do that would be a pancreas or a kidney transplant, because liver transplants will upper abdomen. The one that I generally almost always will warn patients about with a kidney transplant is kidney is an interesting organ in the sense that unlike heart, lungs, or liver, we don't put the kidney in the same place the old ones are. The way the heart, the lungs, and the liver have to be reconnected, we actually have to take the old organ out first, you know, so it gets taken out and then we put the new one in. With kidneys, we don't actually take out the old kidneys. The kidneys get left in place. If you feel for your bottom rib, that's where your kidneys are, towards your back. We put the new kidneys down in the groin and attach them to the blood vessels that go into the leg. So the nerves that we worry about, there is one nerve that tends to run near the kidney that gives sensation to the inner thigh. That nerve can sometimes be affected. It's only a sensory nerve. There are some other nerves going into the leg that can be damaged by the retractor sometimes, but that usually will improve with time.
And then any comment about the incidence of hernia or how to prevent a hernia or when to follow up?
You know, hernias are something that we do see after transplant. Part of it is because you have to be sick enough to get a transplant, so you're pretty sick at baseline there. And then even if we close everything, some of the medicines that we put you on post-transplant make wound healing difficult. So there are medications like prednisone, which is a steroid, that makes wound healing difficult. Some of the immunosuppressants can make wound healing difficult. And so it's a balance of making sure that, you know, your body's not going to fight that organ. Generally, what we tell patients, they have to be careful with heavy lifting. They have to be careful, you know, with anything that stresses their core muscles. Those are things that are important to watch in the first 3 to 6 months. If hernias do occur, they can be repaired. And we do see patients every so often for those.
Thank you. I'm going to click over to the next slide. These are some things that we'll be discussing in upcoming transplant talks. Some of these common concerns post-transplant. I think medications, you know, that's an issue that is lengthy and we should, you know, have a good conversation with the pharmacist about. We touched on the idea of rejection a little bit, exercising, when life gets back to being quote unquote normal, things like this. I guess, you know, we have about 7 minutes left. I wondered if we could go down the line and you, the panelists, if you could give us any of your, I would say your most important thoughts or recommendations for someone who is just entering into the transplant phase of treatment or someone considering the transplant process. Shannon, we'll go ahead and maybe start with you, if that's okay.
Sure. I speak to patients a lot when they first get referred and they have a lot of questions and they're really anxious and worried. And I just try to reassure them and let them know that, you know, the first thing you're going to get when you come in is education. You're going to meet with a multidisciplinary team and just learn a lot. And just make sure you have your care partner. And in terms of the insurance, work closely with your financial coordinator and always reach out if you have questions at any time.
I think I'll say for Shannon that you should never change anything without speaking to someone at your transplant center if you're in the middle of that process. It's important that you use your transplant center as a resource. They want to be a resource. They want to be involved in your care. So if something feels wrong or concerning or different, you should always reach out. Cherie, do you have anything, any parting comments or words of wisdom for the group?
Yeah. So, you know, this is a team effort. It works on everybody's end. We all want the same result. We all want you to do well with transplants. So that means, you know, talking to us, keeping us posted as, you know, your providers to what's going on. If you have questions, we want to make sure you're comfortable with the plan, because, you know, this is not just as simple as a surgery. This is a life, you know, commitment that is going to affect every part of you. So we want to make sure you're comfortable with that. So questions are, you know, we want to answer them. So staying in touch, letting us know what your thoughts are, letting us know if there are changes in your health. All of these things are really important to keep us posted on, so that we can, again, provide the best care and help you through this whole process.
Right. So really thinking of your transplant center as your new primary care center. I used to joke with patients that during the evaluation phase, you're kind of dating, figuring out if you want to know each other. And then after transplant, you're married, but like forever, no option of divorce, married. So you are stuck together till death do you part. And it can be a wonderful partnership if everyone's communicating well. You know, the best partnerships are communication. So I think that communication piece that you touched on, Cherie, that's really important. Dr. Wilkinson, anything you'd like to share?
I think that, you know, I think I've said a lot about these things. What I would say is, you know, the most important thing that for us to be able to do our job is for people to be organ donors. The vast majority of transplants that we do are from deceased donors. So many, you know, some organs we can't do living donors from because you only have one of them and you need it. And so, you know, people being organ donors and encouraging people to be organ donors is one of the most important things that we can do as a community, and you know, encourage your family. You can do it when you go get your license. It's very easy to do. You can do it online. In fact, I would say a lot of the donors, because I also do the donor operation, so sometimes I go doing the operations to take the organs out. Many times the people who have chosen to be donors are what we call first person designated. So it means it's on their license. They have that little heart on there saying that, yes, I wish to be an organ donor. And that's something that we work very hard. And I think that, you know, one of the things that gets, you know, very exciting on TV, but I can tell you when we actually do that, we do actually take a moment in the operating room to honor the life of the donor, you know, before we do anything, and we, you know, recover the organs, understanding the fact that these organs are going to help someone else. There's a very solemn moment where we take time to honor the life of the donor and think about the gifts they're about to give. So it's not just, you know, oh, we're here to do this. We really do take it, everyone that does this takes it very seriously, that for someone else to have a benefit, you know, someone did have to pass. And so that, I think, you know, the more people we can have be organ donors, we do take it all very seriously, treating those people with respect. That's what allows us to give someone else that gift of life.
I think that's a wonderful comment. Our next transplant talks is actually going to be in partnership with Midwest Transplant Networks, reviewing the donor family experience and kind of talking about really how to fully thank those donor families, and the emphasis on corresponding with your donor family if they're open to that. So I think that point, Dr. Wilkinson, is very well made. And then Andrew and Vicki, I would love to hear, you know, from you, any words of hope or wisdom that you would like to impart on people that are kind of just embarking on this process or are not yet transplanted.
Yeah, I would just say that of the people who I have spoken to that are pre-transplant, there's this vision of post-transplant being hard and not looking normal and whatever it is, but you know, post-transplant can be amazing, and it is amazing. You know, there are certain things that you have to do. You have to take your medicine, but as long as you take care of yourself and you take your medication, you listen to your doctors and you do the things that they want you to do, you will live a normal life. And you know, I'm just blessed that I got a chance to. And so post-transplant can be amazing.
Wonderful. Well, go ahead.
No.
And then go ahead, Vicki.
Oh, I was just going to add that as the caretaker of the recipient, it is stressful in many ways. I mean, the patient has the stress of the health, but for a lot of us, we are taking care of our families, and we are trying to make sure that two little boys are living their normal life as much as possible. So I would just say to accept any help that anybody is willing to offer you. Going through it, I didn't even know what help to even ask for. I didn't even know what I needed. So it was very appreciated. If a friend called and said, I'm going to pick your boys up from school and take them out for dinner and I'll return them to your house. So just to be open to accepting that help because you need it.
That is a very important comment. The idea of caregiver fatigue is very real, and transplant is a marathon. And if you're lucky, it gets to be a very, very long marathon, but still it can be stressful. So I really do think that is such a good point, that for the accepting help when it's offered and letting resources come to you as well. I think that we have a really wonderful Transplant Talk recording about mental health of not just the patient, but of the care partner, really recognizing that. And again, I just to sort of plug Gift of Life again, I feel like that's a really wonderful opportunity for to seek transplant mentorship. We do mentor patients, obviously, but and recipients, but we also really want to mentor the care partner community as well, because that is a real bulk of the duties are on the care partner, can feel very weighty. I just want to really take a minute to thank all of our panelists and participants. This was such a wonderful discussion. I was so glad to do my first transplant talk with all of you. I appreciate it so much. We will be sending out a recording of this presentation for you to share. And then please keep an eye on your email and other social media outlets for more transplant talks. I commented on this, but our next one will be reviewing the donor family experience. I would also really love to hear from people. When we send out the recording, we'll send back a feedback survey. I'd love to know any comments about the presentation itself, and then potential areas of interest for future presentations. So I just want to again say thank you so much, and I hope everybody stays warm and gets home safely.
Thank you.
Thanks,
Thank you, everybody.
guys.
Bye, everybody.
Thank you.